This is the PowerPoint for respiratory medications. Start with the first slide. So these are your objectives. We're going to discuss drugs for the lower respiratory airflow disorders and drugs for upper respiratory disorders. The reason that we have them broken up this way is because you need to understand what does the drug do in the body, why are we using this drug, or who do we use this drug on, and what types of effect the medication is going to have on the body, and when do we need to talk to the doctor. So if your patient has an upper respiratory problem, the medications that you'll use are going to be different than the lower respiratory. So make sure you review that anatomy and physiology in case you have forgotten. Next slide. Drugs for lower respiratory airflow disorders. So our drug classes are beta-2 adrenergic agonists, anticholinergics, methylxanthines, glucocorticoids, mast cell stabilizers, and leukotriene modifiers. The diseases that drugs for lower respiratory airflow disorders will help are asthma, COPD, chronic bronchitis, emphysema, and EIB, exercise-induced bronchospasm. Next slide. Oh, and I want you guys to see in this picture, she's using an inhaler in this top picture, and in the bottom picture, this is actually a nebulizer. You can see underneath the mask portion, this blue part here, it opens up, you put a liquid in, which is the medication, close it back up, and then you have them take nice, slow, easy breaths to get all of the medication. Okay, next. Oh, a question already. After receiving a nebulizer treatment with a beta agonist, the patient complains of feeling slightly nervous and wonders if her asthma is getting worse. What is the nurse's best response? Is it A, this is an expected adverse effect, let me take your pulse? Is it B, the next scheduled nebulizer treatment will be skipped? Is it C, I will notify the physician about this adverse effect? Or D, we will hold the treatment for 24 hours? All right, the answer is A. Nervousness, tremors, and cardiac stimulation are possible and expected adverse effects of your beta-2 agonists. The other options are not correct. So, speaking of beta-2 agonists, let's discuss what a beta-2 adrenergic agonist is. It's used for the relief of bronchospasms, prevention of exercise-induced bronchospasm. This is one of those this is an inhaler that you would refer to as a fast relief inhaler or rescue inhaler. The effect of this medication is for the sympathetic nervous system, so it opens up your bronchioles and it increases ciliary motility to decrease histamine in the lungs. The prototype is going to be for your rescue or immediate acting will be albuterol. Your long acting, so for long-term treatment, we have formoterol or salmeterol, which are for stable COPD patients, and they can take that if they're having trouble with wheezing. Expected effects from this medication, so basic side effects that we know will occur, tachycardia, palpitations, and tremors. We need to make sure we monitor for chest pain in cardiac patients. This drug is already going to increase their heart rate. It can cause palpitations or chest pain in patients that already have a cardiac problem. So we need to talk to the doctor about potentially taking a different drug if they already have a cardiac issue. The patient needs to be educated that they need to avoid caffeine, watch for exacerbations, avoid triggers like smoke, pollen, etc., to keep with you at all times, and to take before exercise. Now, a lot of people think that they can just take this pill or take this inhaler frequently. They can just use it whenever they want and as many times as they want every week, but they need to actually notify their healthcare provider if it is used more than 2 times per week. It can be given inhaled or orally. For your inhaled for your immediate acting and orally for your long acting. And they need to make sure that if they have glucocorticoids scheduled, that they take their bronchodilator before their steroid. Now think about that for a second. Why would we want them to do that? That's correct. We've got to open up those airways and open up those bronchioles so that we can get the medication down. Let's talk about cholinergics. These are going to block the action of acetylcholine. Okay. These are used for airflow disorders, helps with bronchoconstriction, and they reduce the secretions in COPD patients. This may sound familiar: Atrovent and Spiriva. These two medications are not for acute attacks. Not for acute attacks, okay? Acetylcholine in your body will cause vasoconstriction of your bronchi and bronchioles, which results in bronchoconstriction. So if we, if we inhibit the action of acetylcholine, we are stopping the vasoconstriction of the bronchi and bronchioles so that our patients can have open bronchioles. Because it is an anticholinergic, we must remember that you will have dry mouth, blurred vision, bronchospasms, hypotension, and dizziness. Or, as you guys know, I love to say, can't see, can't pee, can't spit, can't shh it. That's correct. It is the same as some of the other medications that we have already discussed. Education, if we know that they can't see and they're having blurred vision as an adverse effect, then we know we need to have routine eye exams. For glaucoma, we need to monitor for urinary retention. If your patient is going to receive 2 inhaled medications, we need to wait 5 minutes between giving them. And as you can see here, I have my wonderful picture of a Jolly Rancher, and this little apple says, keep on sucking. So if your patient is taking ipratropium, part of your job is to make sure that you help to decrease that dry mouth by giving them hard candies to suck on. All right, next slide. Another question. Patient is in an urgent care center with an acute asthma attack. The nurse expects that which medication will be used for initial treatment? Is it A, an anticholinergic such as ipratropium, B, a short-acting beta-2 agonist such as albuterol, C, a long-acting beta-2 agonist such as salmeterol, or D, a corticosteroid such as fluticasone? That's correct. B, a short-acting beta-2 agonist. We just talked about albuterol being a rescue inhaler. And if your patient is having an acute asthma attack, a short-acting beta-2 agonist is going to be used to help reduce airway constriction quickly and to restore airflow to normal levels. Next slide. Ooh, methylxanthines. This is one that you guys are not going to see very frequently. It's also one that's not used very often anymore, but it's still one that you need to become familiar with because of the adverse effects. So the prototype that you need to be familiar with is theophylline, and all it's going to do is relax smooth muscle of the bronchi. So if it relaxes the smooth muscle, it'll help it to not constrict if a patient is having issues with chronic stable asthma. We used to use it for COPD, but they do not prescribe this anymore for that due to the adverse effects. It can be, we also want to make sure we don't give it to smokers. They'll metabolize the drug too quickly. We want to make sure that we know that it's given orally, an extended release. We do not want them to double the next dose. It can also be given IV for emergencies. You must give it slowly at like a dose per minute dosing. Now, the thing that we need to remember is that the adverse effects where they're not at a therapeutic level anymore, but not yet toxic, are insomnia and restlessness. Okay, so they're not therapeutic level anymore. It's going to be insomnia and restlessness. If we are at a toxic effect, the methylxanthines for theophylline, your patient's going to show seizures and dysrhythmia. You must tell the doctor if there's an adverse or toxic level because we need to stop the drug. We can give activated charcoal. We need to watch the heart rate and the rhythm. And then for dysrhythmias, we're going to give an antidysrhythmic if it's life-threatening. Of course, what are we going to give for seizures? An anticonvulsant. Very good. So education, we need to reduce or eliminate caffeine, and that the patient needs to get lab tests or monitor blood levels. Something that you'll notice with our medications is we try not to give out medications that we have to monitor blood levels for or have a very narrow therapeutic level because it's harder for the patients to stay at a therapeutic level. So Not only are the adverse effects a reason for patients not to take this medication, but it's also the fact that we have to monitor blood levels for it. There are multiple drug-to-drug interactions, and we need to, the toxic levels are seizures and dysrhythmia. All right. Oh, look, you guys could teach me about this. Do you guys want to do that? Do you guys want to make a recording for me and teach me all about glucocorticoids? Because I'm going to tell you, you guys pretty much know this information by now. So who do we use them on? Asthma will suppress the immune system and decrease inflammation. The mechanism of action is it prevents the release of leukotrienes, prostaglandins, histamines, and it minimizes white blood cells and leukocytes and eosinophils, so it helps to decrease edema in the airways. Your basic side effects, oral candidiasis. Now, if you take an inhaler that is a steroid and a side effect is oral candidiasis, how do we teach our patients to prevent this side effect? Wash your mouth out, right? It's pretty simple, pretty straightforward. If it's a steroid, they need to wash their mouth out. Swish and spit, okay? Some other effects that come with glucocorticoids that you guys should be familiar with: muscle wasting, bone demineralization for osteoporosis if they're on it long term, elevated blood glucose, you guys know that one, and increased susceptibility to infection, just like your other steroids. You can take it intranasally and you can take it inhaled. So oral, intranasally, and inhaled are the three different methods of administration for glucocorticoids. This is on a regular schedule because it is a steroid. We do not take these PRN, and this is not a rescue drug. One more thing about steroids that you guys already know. How do we come down off of them, or how do we decrease our dosage slowly? We taper. Very good. Okay, let's go to the next one. Mast cell stabilizers. Now, we just talked about how our glucocorticoids are going to prevent the release of leukotrienes, prostaglandins, histamines, minimize our white blood cells and leukocytes and eosinophils from going to, activating, if you will, which helps to decrease the edema in the airways. Well, you'll see here that mast cell stabilizers are also an anti-inflammatory. They reduce bronchial inflammation prophylactically, so that means before it happens. For mild to moderate asthma, they'll prevent exercise-induced bronchospasm and seasonal allergies. EIB is exercise-induced bronchospasm. If we're using it for our asthma patients, we need to make sure they take it as prescribed. It can take several weeks to work, so they need to make sure they're aware of that. If it's for exercise-induced bronchospasm, then they need to make sure that they take it 10 to 15 minutes prior to the activity. If it's for seasonal allergies, they need to take it prior to performing a task with exposure. So if you're going to go out and mow the lawn, then you need to pop one of these guys in your mouth. And the one you'll need to remember for prototype is cromolyn. You're going to take cromolyn, then you can go do it. I want you guys to understand that mast cell stabilizers do not bronchodilate. These are not bronchodilators. They suppress inflammation, okay? Very similar to our glucocorticosteroids. However, they have minimal adverse effects, unlike our glucocorticoids. If your patient has a sudden rash, swelling, or wheezing occurs while they're on this medication, they need to call their doctor. That is an adverse effect. Question. The client asks the nurse about the advantages of mast cell stabilizers over antihistamines in the treatment of allergies. What is the best response by the nurse? Is it A, they relieve the clinical symptoms more effectively? B, they act on a cellular level to produce a better response? C, they can be used to prevent a clinical response? Or D, they are newer and more effective drugs? Yeah, are you sure that's the answer? Yeah, it's C. The greatest impact of the mast cell stabilizers is that they can be used as prevention of the allergy or clinical response. Mast cell stabilizers do not treat symptoms more effectively. They are just best for prevention of the allergic response. They are prophylactic, okay? Mast cell stabilizers do not produce a better response. They're used for prevention, okay? Let's look at the next one, which are leukotriene modifiers or anti-inflammatories. Mechanism of action, we're going to decrease inflammation by preventing the activation of leukotrienes. Now, leukotrienes are inflammatory chemicals that the body releases after coming into contact with an allergen or allergy trigger. And they can cause tightening of airway muscles and the production of excess mucus and fluid. So if your patient has allergic rhinitis, asthma, or exercise-induced bronchospasm, this could be a beneficial drug for them. So the prototype that we're going to look at is montelukast or Singulair. This is a PO drug, okay? This is used for long-term use. This is not a PRN medication. Some adverse effects that can occur are behavioral changes, suicidal thoughts or behaviors, agitation, and anxiety. Education for your patient. They need to take 2 hours before exercise, and they can only take it every 24 hours. So they either take it 2 hours before exercise once a day, or they take it before bedtime, especially because asthma symptoms will worsen at night. And see how she's taking her pill and then she's going to bed? You see how I did that there? Okay. Next slide. Oh, look at the question. A patient has prescriptions for 2 inhalers. One inhaler is a bronchodilator and the other is a corticosteroid. Which instruction regarding the inhalers will the nurse give to the patient? A, take the corticosteroid inhaler first. B, take the bronchodilator inhaler first. C, take these 2 drugs at least 2 hours apart. D, it does not matter which inhaler you use first. The answer is B. Take the bronchodilator inhaler first. Remember, I said this earlier. An inhaled bronchodilator is used before the inhaled corticosteroid to provide bronchodilation before administration of the anti-inflammatory drug. Good. So let's move on to drugs for the upper respiratory disorders. We have first-generation antihistamines or sedating antihistamines. Then we have second-generation antihistamines or non-sedating antihistamines. We have sympathomimetics. Yes, I said that correct. Antitussives, expectorants, and mucolytics. And the diseases that we're going to treat are sinusitis, rhinitis, laryngitis, and pharyngitis. So let's get this one. The prescriber has changed the patient's medication regimen to include the leukotriene receptor antagonist, montelukast, to treat asthma. The nurse will emphasize which point about this medication. A, the proper technique for inhalation must be followed. B, the patient needs to keep it close by at all times to treat acute asthma attacks. C, it needs to be taken every day on a continuous schedule, even if symptoms improve. D, when the asthma symptoms improve, the dosage schedule can be tapered and eventually discontinued. The answer is C. It needs to be taken every day on a continuous schedule, even if symptoms improve. These drugs are indicated for chronic, not acute asthma, and are to be taken every day on a continuous schedule. And these drugs are taken orally. Okay. First generation antihistamines, sedating antihistamines. It is our friend. It is the one that you hear a lot. It is diphenhydramine or Benadryl. Yes, this is a first generation antihistamine or sedating antihistamine. Everybody knows that pink pill will cause you some drowsiness, dizziness, and even dry mouth. These are all expected side effects because it is an antihistamine. Okay, so this is going to be used for management of mild allergic reactions like allergic rhinitis, mild transfusion reactions, urticaria, which are raised hives, itchy welts, or rash. It can also be used for anaphylaxis and motion sickness. The mechanism of action, it's going to block the release of histamine because it's an antihistamine, which is why it is so effective. It is going to block it. So let's think back to when we talked about in med-surg, we talked about hypersensitivity reactions, and we said that some people get allergy testing. Well, If your patient is going to have allergy testing, do we want to block the release of their histamine? The answer is no, we do not. We need to make sure we stop 4 days prior to allergy testing. These people should not take alcohol or CNS depressants with this medication. It could be life-threatening. No driving, and they must notify their provider immediately if difficulty urinating occurs. Contraindications for this medication include BPH, glaucoma, newborns and kids under 2, and people with acute asthma. So let's talk about why second generation antihistamines that are non-sedating are better. You guys have probably heard about these. So we have Zyrtec and Claritin, or cetirizine and loratadine. Those are your prototypes, okay? Zyrtec and Claritin. These do not inactivate histamine. They have minimal anticholinergic effects, so they have less side effects, okay? It's used for allergic rhinitis, chronic idiopathic urticaria, so like hives or rash with an unknown cause. Zyrtec and Claritin. You guys have probably heard of these. You've probably even taken them yourself. You may get a little drowsy, you may get a dry mouth or a throat or nose, but you have very minimal side effects compared to your first generation, just like your antipsychotics, right? The higher the generation, the less side effects, or at least that's the goal. We don't want them to take these with other antihistamines. So should we take Benadryl with Zyrtec? The answer is no, okay? We don't want to give this to infants under 6 months or breastfeeding women. We need to watch our labs in patients with kidney or liver problems. We need to avoid our alcohol and opioids and hypnotics because those are all CNS depressants, and these can still cause a reaction with those. You also need to watch out for interactions with theophylline. This can reduce the clearance of second-gen antihistamines, which can lead to toxicity. All right. Sympathomimetics. Say it 5 times fast. I'm not going to, but you will. Okay. This is used for reducing nasal congestion from allergic rhinitis, sinusitis, common cold, not for sneezing or itching. Let me say that again. It is used for nasal congestion from allergic rhinitis, sinusitis, or the common cold. You know these bad boys as phenylephrine or Sudafed, pseudoephedrine, right? These are the ones that are going to help to open up the nasal passages by activating the alpha-1 adrenergic receptors in the body at those at the blood vessels. Okay. Prolonged use of this can a patient should notify your provider if the CNS if they're taken with CNS stimulation. So clearly my brain is struggling. So let's just start this slide over. I'm so sorry. Okay, let's talk about Sudafed or neosynephrine, also known as pseudoephedrine, Sudafed, or phenylephrine, neosynephrine. These drugs are in the category of sympathomimetics. These are for nasal congestion from allergic rhinitis, sinusitis, and the common cold. We do not use these for sneezing or itching. The effects that the patient should expect are that the nasal passage will open by activating the alpha-1 adrenergic receptors. These are not long-term use medications. We only use them when necessary. We need to watch for hypertension, tachycardia, and palpitations. Your patients can overdose on these, so we really need to watch for those signs and symptoms. You have alpha-1, one heart, it is going to activate that, then you're going to have side effects that are cardiac related, okay? They need to take a prescribed dose, and if they have a history of hypertension, we definitely need them to check their blood pressure while they're on this medication. Some major education for this patient is if they take it for more than 3 to 5 days, they are going to have an increase in congestion, also known as rebound congestion, okay? when they use the nasal spray, which is Afrin. Afrin is one you might be familiar with as well. Some effects that can occur when they take these medications are agitation, anxiety, insomnia, because we are stimulating the CNS system, and systemic vasoconstriction, so our tachycardia, our palpitations, and hypertension can occur. All right. Antitussives. These are used for suppressing a cough, usually in our upper respiratory infections, allergies, chronic cough, or a non-productive cough. Do you see how I said that? Non-productive cough. If we are suppressing the cough reflex in the brain and we are stopping the cough, do we want to do this if our patient needs to cough up the crap? No, that's correct. So we only use this in non-productive cough or a chronic cough or for allergies. Your prototypes, you have codeine, which is an opioid drug. We discussed that earlier when we talked about opioids. We have dextromethorphan or Deltham, which is a non-opioid. And then we have benzonatate or Tessalon pearls. The opioid drug is going to have the same symptoms as your regular opioids. So we're going to watch for sedation, drowsiness, constipation, respiratory depression. We want to make sure that we watch out if our patients are on SSRIs or MAOIs. Remember, that can help reduce the respiratory drive. So we want to make sure that we watch for patients with substance abuse history. And we want to make sure that we always give the lowest dose possible. If your patient is taking codeine and they get too much and they try to change their position by getting up and they get a little dizzy, or they have a respiration of less than 12, do you guys remember what to do? Okay, well, the first one is they need to change position slowly, right? So they don't need to jump up. We'll get orthostatic hypotension. We need to make sure that we teach them to be on a high fluid, high fiber diet, because we know that they can be constipated. And if they have a respiratory rate less than 12 and we've assessed that it's necessary, we can give naloxone or Narcan, right? We need to make sure we teach our patients about combination drug therapy. Combination over-the-counter drugs have multiple side effects. So if the primary symptom is a cough, then the patient should just consider purchasing a single preparation of an antitussive instead of a combination drug. I know a lot of people think that like cough and chest congestion are great, or an expectorant and a cough suppressant are great. But if an expectorant is supposed to make you cough and a cough suppressant is supposed to keep you from coughing, does that even make any sense? It doesn't. It doesn't, just in case you weren't sure. Okay, let's move on to the next one. Oh, we have a question. The client tells the nurse that her symptoms have become worse since she has been using oxymetazoline or Afrin for nasal congestion. What is the best assessment question for the nurse to ask? Can you describe how your symptoms have gotten worse? B, how long have you been using the medication? C, may I take your temperature? D, are you using any other inhaled medications? So what is the best assessment question for the nurse to ask for a patient that states that her symptoms have become worse since she has been using Afrin for nasal congestion? The answer is B. How long have you been using the medication? So if you recall a few minutes ago, we talked about the rebound congestion occurring if the medication is used for too long. So length of treatment is the best assessment question. Right? We're almost done there. Let's talk about expectorants. These are used for colds, upper respiratory infections with lots of mucus, bronchitis to help with mucus removal. Mechanism of action, we're going to reduce the surface tension of secretions to help thin the mucus so the patient can cough it up. So an expectorant doesn't actually do anything to help actively cough up a medication, or I'm sorry, it does not actively do anything to help the patient to cough. All it's going to do is thin the mucus so that the patient can actually cough up the crap, the gunk, right? Your prototype is going to be guaifenesin, and also known as Mucinex. Some effects that can occur from this: dizziness, drowsiness, headache, GI distress, and a possible rash can occur, and that would be an allergy to this. We only want to take this medication as needed, so PRN. Patients need to make sure that they change positions slowly. They need to give with food to decrease the GI upset. They need to stop the drug if the allergy occurs. They need to continue to increase fluids, because what are fluids going to do to the gunk? They're going to thin it out too. Very good. And if we have to watch out, because if your patients have phenylketonuria, it's the reason this is a thing is because there is a sensitivity or an interaction that can occur if people are intaking aspartame, and so phenylketonuria means that they have an aspartame sensitivity, and a lot of diabetics don't eat sugar, they eat foods that have aspartame in them. And that's it. Expectorants are pretty straightforward. So let's just move on to the next. Look, another question. Like you guys didn't know there was going to be one. Okay, the nurse is providing instructions to a patient who has a new prescription for a corticosteroid metered dose inhaler. Which statement by the patient indicates that further instruction is needed? This is a select all that apply, so I'm just going to give you a second between each answer to tell me yes or no. A, I will rinse my mouth with water after using the inhaler and then spit out the water. B, I will gargle after using the inhaler and then swallow. C, I will clean the plastic inhaler casing weekly by removing the canister and then washing the casing in warm soapy water. I will then let it dry before reassembling. D, I will use this inhaler for asthma attacks. E, I will continue to use this inhaler even if I am feeling better. F, I will use a peak flow meter to measure my response to therapy. So which statement by the patient indicates that further instruction is needed? And the answers are B. The inhaled corticosteroid is a maintenance drug used to prevent asthma attacks. It is not indicated for acute asthma attacks. Rinsing the mouth with water is appropriate and necessary to prevent oral fungal infections. The water is not to be swallowed after rinsing. Remember, I said swish and spit, right? The patient needs to be given instructions about keeping the inhaler clean, including removing the canister from the plastic casing weekly and washing the casing in warm soapy water. Once the casing is dry, the canister and mouthpiece may be put back together and the cap can be applied. The glucocorticoid may predispose the patient to oral fungal overgrowth, thus the need for implicit instructions about cleaning the inhaling devices. Use of a peak flow meter assists in monitoring the patient's response to therapy. And the medication needs to be taken as ordered every day, regardless of whether the patient is feeling better. So B and D are the answers to this question. Last but not least are mucolytics. So this is a cool medication. You guys have seen that, well, you guys see my little skull with the smelly stuff coming off of him. This medication reeks, okay? They get GI distress as an effect from this medication because of how bad it smells. They will get nausea from this smell. This drug smells like rotten eggs. We do not want the patient to swallow their secretions. We want them to spit them out. We want them to spit them into tissues, a disposable bag. Okay, what this is going to do is it's going to decrease the viscosity by breaking protein linkages in the mucus, which will then thin the mucus for expectoration. So think about your cystic fibrosis patients with thick, viscous mucus, okay? This is also used as an antidote for Tylenol overdose, PO or IV. You need to make sure that we auscultate our lungs frequently because crackles will indicate that we have trapped secretions. You may need a bronchodilator along with the mucolytic to enhance the effectiveness. It's okay to use suction equipment. We need to check our patient's ability to cough before we give this medication because the idea is that they are going to cough up their secretions. So if they cannot cough, this is not a wise choice to give a patient. We need to watch in our asthma or bronchospasm patients. And that's it for this one. Pretty straightforward too, huh? And acetylcysteine is the prototype for mucolytics. Last question. When evaluating a patient's use of meter dose inhaler, the nurse notes that the patient is unable to coordinate the activation of the inhaler with her breathing. What intervention is most appropriate at this time? A, notify the doctor that the patient is unable to use the MDI. B, obtain an order for a peak flow meter. C, obtain an order for a spacer device. Or D, ask the prescriber if the medication can be given orally. The answer is C, obtain an order for a spacer device. If a patient is struggling with following the steps for using a meter-dosed inhaler, the best thing to do is to give them a spacer. I'm going to walk through the steps for a meter-dose inhaler, MDI, so you can see how tricky it can be for some patients. So the first step, we're going to shake our medication back and forth, okay? We're going to hold it 1 to 2 inches from the open mouth. We're going to take a deep breath and exhale. We're going to put it up to our lips and administer the medication and inhale slowly for 3 to 5 seconds. We're going to hold our breath for 10 seconds after it's in there. Then we're going to remove the inhaler and we're going to slowly exhale. If it is a corticosteroid, we will teach our patients to rinse their mouth out afterwards and spit. All right, there you have it, you guys, respiratory medications. I hope you enjoy the beach ball game that you guys are going to be playing with Professor Moreni, and I will see everybody the following week. Have a good day.